People are risk. Okay, so last question, the answer was selective serotonin reuptake inhibitor, and he is going for K, which is selective serotonin reuptake inhibitor. Severe mood swings may be managed using selective serotonin reuptake inhibitor like citalopram. Okay.
But this will be 10 mg or 20 mg because some EMQs come with the same options, but in this it is just SSRI. But if it is 10 and 20,
we
which
will
we will
start,
choose?
look here. If she first line is to start with low dose. If no effect, go for the high dose. So if you are just starting here, this is her first time, give her the 10 mg. If not control, go for 20 or 40.
Okay.
So you go from lower to higher, except if she is already in a very severe form. Like you can skip, because if you read the guideline, it says that it is individualized treatment, so you can skip some steps. You should, like some patient, cognitive behavioral therapy alone will not be of any use to them. Like if she is coming for the final type, the last type, this cannot help her. If she has the third type, just cognitive behavioral therapy will not control her symptoms. So you can individualize the treatment. You can skip some points. Okay, let's go. Next question.
هو الكويشن اللي طلع selective serotonin reuptake.
ايوه
اوكي لسه جايه.
اوكي
we reach number 3
go.
or
3.
no, question number 3 or
yeah go for number 3.
طيب 39-year-old woman present with severe buffness of the feet and bloating 10 days before her period every month. Her weight increases marginally and she struggles to fit into her well-fitted clothes periodically. She works as stewardess and finds it distressing. It's distressing. She has no mood changes to report.
She has all the classical features of water retention, so she should be benefited by spironolactone.
Yeah, spironolactone. She is just having,
which is a diuretic also.
Yeah, spironolactone is a diuretic. So this is the treatment. Spironolactone is an effective measure. It is a potassium-sparing diuretic that may be helpful, particularly with water retention prior to period. Sometimes some patients with increased estrogen and progesterone, they will get, even with the regular, like the normal estrogen and progesterone levels, they will get some retention. Okay, sorry. Let's go for the next.
Okay, number 4.
Sorry,
number 4.
Yeah.
43-year-old woman present to the gynecology outpatient department with complaint of severe mood swings prior to her 24-day cycle lasting more than a week. She is very recent and she admits to worsening of mood cyclically, but work has also been stressful of late. She explains that she feels of total lack of control and is prone to episodes of feeling. السكرين اتغيرت.
Yeah, sorry. He is giving me as a recording.
Okay, two, lack of control and is prone to episodes of feeling tearful. She wanted to know if this is due to her hormonal cycle changes or work stress alone.
Okay. Yeah, this one
طب قولي كده
is a
الكيورد.
tricky. This one is a tricky one.
مم.
Now you
Keyword.
want to confirm the diagnosis of BMS.
Yes.
Feeling
That
tearful.
There is one thing that can be used to confirm BMS, which is
GnRH for 3 months.
For 3 months. So here she wants to have a definitive diagnosis. Definitive diagnosis being made by this. It will treat as well as diagnose. Okay. So
GnRH analog.
Yeah, here it is GnRH analog. Help to a certain extent by blocking the gonadotropin hormone. Any cyclical changes alone will improve with this intervention. So any PMS, pure PMS will be treated. Okay. Let's go for the next question. Subfertility.
Our FGNHRH analog will treat her, so it will be premenstrual syndrome, صح?
Yes.
If not, if can't treat it, so I will referral to psychiatry or what?
You will tell her that this is stress related.
Yes. This is a gynecology psychologist.
Yeah.
Okay. Number one, question number one, 30-year-old woman and her partner present to the fertility clinic anxious to conceive. They have been trying for a pregnancy for 2 years now. The woman has regular cycles with normal body mass index and no prior medical illness. Semen analysis show a volume of 2 milli with a count of 4 million and 5% normal form and 35 have progressive mortality. I think normal semen analysis.
Oligospermia.
Oligospermia.
يبقى هعيد
4 مليون.
تاني.
Count 4 million. supposed to be 12 to 15. I think
we should revise this now.
Yeah, we should repeat. We should repeat the semen analysis because it's on the border. It's on the borderline. Yeah.
It is first. We will try to memorize. I think this 1.5 ml is the normal volume, and pH is 7.2. Okay, no problem. And third one is this count is 15 million. And per ejaculate is 39 million. And WHO. Motility is, I think, 32% and 40% progressive. And normal forms should be 4. Normal forms should be 4. Yes. Yes. Yeah. Yeah. Can I read 1.5 ml.
Look.
Total sperm 39 per ejaculate. This is per ejaculate. But sperm concentration is 15 million. This.
Yeah, 15. This is 15 million.
And total motility is 40. And progressive motility, you minus 8, it becomes 32.
Yeah.
And then vital forms, yani ke which morphologically vital forms are 58. This we have to memorize. And normal forms are 4. Only 4 if sperm morphology is 4%, this is sufficient. pH is 7.2, greater than 7.2. And then this the other are not so important, but anyhow, yeah. Fructose more than 13. I think this is sufficient for us, upper portion.
Yeah, till BH is enough.
Yes.
Till BH is enough. Okay, I'll copy this image. I'll send it to the group.
Okay.
Okay. I didn't, sorry, someone is saying accept. I already, I'm not putting a waiting room. Everyone is gone. I didn't put a waiting room. Okay, let me just answer here. There is no waiting room. Okay. So this one you have to know, and I already shared to the group. Okay. So now she has the semen analysis. The volume is 2 ml, which is normal. Count is 4 million. This is low. No.
Count should be minimum, should be 15 million.
15.
Yeah.
15.
Oh, yes. Sperm concentration 15. Yes.
Sperm concentration. Sperm concentration.
Yes.
Look,
this is low.
Sperm concentration, it's supposed to be 15. Now it is 4. This is low. This is oligospermia.
Yes.
Okay.
Total
and
9.
Yeah, and normal form is 5. This is low.
No. Normal form should be at least 4%. 5%. It's above.
This is okay. Normal form's okay.
Yeah.
Normal form is also okay, and the progressive motility is also okay.
Is okay.
So
only the
count.
The number.
Yeah, only the count. So count, we need to
repeat within 3 days.
Ideally, we should repeat because sometimes it can be faulty collection.
It should be repeated, but repeated, I think it has a time limit. I think after 3 months.
90.
Yes.
After 3 months.
Yes. If very severe, then immediately. But if it is
3 days. Within 3 days.
Look, if it is very severe, if it is azoospermia or like 1 million very oligo, you can do it immediately. Second day he can give you, but if it is like this 4, you can repeat it after 3 months. So let's see what
immediately 3-4 days.
He said he also went for F, which is a semen analysis. He will repeat. Let me show you the answer. I'm sorry. Okay. Here. Yeah, subfertility. He is putting it even here. I'll also take this and put it to the group. I will take a screenshot of it and send it to the group. Okay.
So answer is repeat analysis.
Yeah, repeated analysis, and this is the explanation. The explanation, he just put the table, but in words. So I also send this to the group. Okay.
This is what he stop. Can I read it? Okay.
This is the same, man. This is the same. The same as the tip.
Same, yes.
Same as the tip.
Okay.
So let's go for the next.
27-year-old woman present to the fertility clinic with secondary subfertility. She has a 7-year-old child born of normal conception and had a normal delivery. She has ever used only male condom for contraception. Her cycles have been regular until a year ago. She gets very slight bleeding and hasn't had period for 3 months. She complained of vague headache and difficulty in looking out of the corner of both her eyes. Her urine and pregnancy test is negative in the clinic today.
They have given a clincher.
Prolactin.
Yeah, prolactinoma. There is a microadenoma compressing the pituitary.
Yeah.
So she has
Here,
bitoral hemianopia.
The key feature here is that she is having a headache and she cannot move her eyes. So there is something pressing on her brain, affecting her nerves.
And secondary amenorrhea.
So this one,
serum prolactin. Serum prolactin.
Serum prolactin. And if he gave you a serum prolactin and said you will go, what is next? You will go for MRI.
MRI?
Yes.
Yeah.
You brain?
If it is raised. If it is raised.
Yeah, this is what I'm telling. If prolactin is raised, you need to make sure that this is a prolactinoma. So you need to have a visual on the pituitary. So you will go for MRI brain.
Yes, to see either it is microadenoma or macroadenoma. Microadenoma needs the medical treatment, the bromocriptine or cabergoline, but if it is macro, then it needs some surgery, tussica removal like this. Yes.
Yeah, surgical removal. So I'm just giving you alternative to the question to open your mind.
Thank you.
Okay. So question number 3.
32-year-old woman present to the fertility clinic with primary subfertility. Her periods are regular and her husband's semen analysis is reported to be normal. She undergoes a hysterosalpingogram which shows filling of the uterine cavity but no further progression of dye beyond postcorneum. No further progression of the dye beyond postcorneum. يعني في باثولوجي كده في التيوب.
blocked tubes.
Yes.
What is the reason for the blocked tubes?
Laparoscopic assessment.
Yeah. You have to see them to see why.
Laparoscopic assessment.
Yeah, we have to do the laparoscopic assessment.
Yeah, you have to see them.
Laparoscopy is a gold standard for tubal. Yeah.
Yeah, you have to see
internal
them
as well as external. Yeah.
Yeah, laparoscopic assessment of the tube is required to ascertain the findings and the level of damage.
Yes.
Along with complete pelvic assessment.
Yes. If there is one question from me, if it is hydrosalpinx on both sides, bilateral, then what will be the treatment?
Salpingectomy. Yeah. Salpingectomy, because it will increase the
delinking the tubes.
IVF.
Yeah. So salpingectomy, then offer IVF.
Yeah, salpingectomy and salpingectomy will affect the success rate of IVF. It will increase.
The tubal fluid is cytotoxic to the embryo.
Yes. Yeah.
The implantation failure and embryo toxic, so it has to be delinked.
Yes. Good
ligated
answer.
You say ligated?
No, salpingectomy, remove it.
Removal. It should be removal, yes.
Remove it.
Okay.
Because it is just going to kill any baby you got. And this is a standard before doing any IVF. You have to assure that the tubes don't have any fluids in them. This is like step one of the steps you have to do.
32-year-old woman.
Number 4.
30-year-old man present to the fertility clinic with his partner to discuss about starting a family. He admits to being HIV positive and is very compliant with his medications and is under follow-up compliant with his medications and is under follow-up with local sexual health services team. His viral load is found to be 30 copies per milli recently. The woman is 26-year-old and has regular cycles and has had a child in her previous relationship. هو HIV وعنده 30 كوبي والمفروض انه ماشي على ميديكيشن.
دونر
كده
insemination.
نعمل IUI.
No, not donor. Donor why?
Semen wash IUI.
He has 30 copies. Yeah, no donor.
عادي يعني he go well.
Yeah, but IUI is not here. IUI is not here.
Semen analysis لا هنعمل ايه؟
لا.
serum antibodies. انا مش فاهمة هيفكر ازاي. I don't understand how he think.
Can
Anti-Sperm
anyone
Antibodies.
summarize the question, please?
Now he is 30 years old. He is having he is HIV positive. His viral load is 30.
That is good.
He is compliant.
Less than 50.
Yeah, he is compliant with his medications. So what to do next?
I don't change serum anti. Why
I'm
serum anti-sperm?
Look, he is just. There is only one thing here we can do to a male. Now the female is normal. She already had previous baby with before, so she is normal. Nothing wrong with her. All the problem is with the male. So which these investigations can be done to the male?
Only the anti-sperm antibody is the serum
Anti-sperm antibody?
No, anti-sperm antibody. This is for the
I think in this question he mentioned that 30 old man present to the fertility clinic. So as it's the first contact with him, so we have to do semen analysis first.
Yeah. Yes. Only this option is acceptable.
And the only thing that we can do to a man here is semen analysis.
Yes.
We can do prolactin, but prolactin he will tell you that he has fatigue. He has
headache.
Headache. Yeah, galactorrhea, something like this.
Yeah. Semen analysis is normal.
Thyroid, and thyroid for the male don't affect their fertility.
Yes.
No, but if the semen analysis is normal, does he go for natural conception or does he go for donor? IUI.
Now, look, it's according to the viral load. You will, if I think it is, if less than, if it is undetectable, you will go for normal. But if it is detectable, you go for IUI and sperm wash.
Yes.
Right?
Yeah.
Yeah, according to the viral load. We will do this according to the viral load.
So,
and with IUI, it is better. IUI, like they always, if there is viral copies, they usually go for sperm washing to minimize the chance for her to be infected, to minimize it as much as they can. Okay, so let's see.
Anti-sperm antibodies, it is both in female, yeah?
Anti-sperm antibodies, this means that her body is fighting sperm. Why his body is fighting his own sperm? So this is...
I ask about method of contraception. We used it in females.
Look,
okay.
Look, anti-sperm antibodies, this means that her body is attacking the sperm. And by the way, we used to do this in the vaginal secretion previously, but now it is not recommended. It is not even recommended in infertility. Previously it was done, but now it is not recommended.
Hostile cervical factor.
Yeah, we were doing it for the cervix. For the
cervical mucus.
We would take a high cervical swab and send it for the lab to be tested. I used to do this previously in my first years as an OB-GYN, but now it is not recommended at all.
We used to do the PCT, the post-coital test, and then you see that dead sperms are there in the swab.
Yeah, we used to do this, but not anymore. Okay, so let's see his explanation. Semen analysis to find if the parameters are normal. Unprotected intercourse for conception around the period of fertility with the viral load less than 50 copies is recommended. So if the viral load is less than, not only undetectable, sorry for this, if it is less than 50 copies, we can go for
cutoff is 50.
natural.
50 copies per ml is the cutoff.
Yeah. So 50 copies, you can go for normal. More than 50, you have to go for IUI plus sperm washing. Okay. Ectopic.
معلش, before we go to ectopic, last sentence you said before 50 and after 50 we go for what? Washing and intrauterine insemination.
Our cut point for HIV is 50 copies for everything.
Okay.
50 copies is the cut value between CS and vaginal birth.
Okay.
Now 50 copies also is the cut-off value between going for natural conception and doing IUI plus sperm washing.
Oh.
Okay.
Okay. If less. Okay.
Okay. Now he wants the appropriate management for ectopic.
Okay. Thanks so much. 25-year-old woman present with 6-week amenorrhea, severe lower abdominal pain, and tenesmus. Urinary pregnancy test is positive in A and in emergence positive in A and E, and ultrasound shows the presence of a sac in the left adnexia and free fluid in the pelvis and an empty uterine cavity. She tolerates the scan poorly due to tenderness. The beta HCG is reported to be 5,400 international units. She is hemodynamically stable.
She cannot be given medical management because beta HCG is above the cutoff. So laparoscopy, and she's hemodynamically stable, but so laparoscopy would be the best.
Because of severe pain.
So laparoscopy. So which one? Salpingectomy or salpingotomy?
Salpingectomy.
I prefer salpingectomy.
Salpingectomy. Why?
But I didn't if the post tube present, we prefer salpingectomy.
Exactly.
Only if you do a salpingostomy, then there is a chance of recurrence of ectopic, and salpingostomy is only done when she is having no tube on the other side, or she is having infertility and she has poor chance. That only don't.
Okay, what is the difference between salpingotomy and salpingostomy? There is a difference.
You just make an incision, and you just make an incision, and the sac pops out. Yeah, salpingotomy. You just make an incision and you leave it. And salpingostomy, you again
salpingectomy, we remove the tubes.
Repair. Yeah.
No, I'm not telling
salpingectomy is you're removing the tube. Salpingotomy and salpingostomy,
just incision or part of the tube. The area of the sac, يعني, or around it only. Leave the remain of the tube. Remain it. Say, Dr. Amir.
Okay, salpingotomy, you will remove, but you will repair the tube. You will not leave it open. But salpingostomy, you will leave it open.
What? Salpingectomy?
I'm not talking about salpingectomy. We have otomy and ostomy.
Okay.
What is the difference between ostomy and otomy?
Open and non-open.
No, you will open, but one of them you will remove, you will open it and leave it open, and the other one you will remove and repair the damage.
Suture.
That's why we are doing otomy, not ostomy.
Which one I suture the damage?
Salpingotomy.
Otomy.
Otomy. Okay, otomy, I will suture the damage.
Let me. I'm trying. Yeah, I'm trying to get a picture of it, but I cannot.
Okay. No, okay.
But when to go to?
But look, ostomy, you will leave it open. But otomy, you will repair the tube. You will suture it back. Most of us don't know the difference. That's why in the exam, in this book, he is manipulating you to know if you know the difference between otomy and ostomy. I'm trying really to find a picture that have both side by side, but I really can't.
Okay,
but this is a difference.
Presentation, we can search for it too.
But we are doing otomy for this. For ectopic, we are doing salpingotomy. We will remove. Look, you either doing salpingectomy or salpingotomy. Salpingectomy, if the contralateral tube is okay. He never mentioned the contralateral tube, or he never mentioned that this patient had BID before, or had a problem conceiving before. So you are assuming that the other tube is okay. If the other tube is okay, you will remove this tube, salpingectomy. But if the other tube is damaged, you need to salvage this tube because this is now the functioning tube. You will salvage it how? By salpingotomy. Salpingotomy means that you will open the tube, remove the ectopic, and repair the tube again.
Okay, Dr. Amira, thank you.
Okay, but salpingostomy means that you will open it and leave it open. And this is not, salpingostomy usually is done for, I think, hydrosalpinx. You will, if you want just the drainage without removing the tube, you will do salpingostomy, because this means that you will leave it open. Okay, and okay, let's go. I know this is this is something, it's not very important, but you have to know these terminology. Okay, so this one we are going for.
Someone?
This one we are going for salpingectomy, laparoscopic salpingectomy, and this is explanation. Laparoscopic salpingectomy is advised if an ectopic pregnancy is found on laparoscopy and the patient has acute bleeding loss into the peritoneal cavity. The contralateral tube is checked to ensure that it appears normal during the laparoscopy. Okay, let's go for the next question.
Okay, 30-year-old woman present to the early pregnancy unit with mild spotting, BV, and abdominal pain at 8 weeks gestation. The pregnancy test is positive. Ultrasound reveals an adnexial mass of 8 millimeter by 4 millimeter alongside the right ovary. There is no free fluid. Beta HCG 150. هي adnexia mass 8 ملي 8 ملي 4 ملي alongside the
Beta
right
HCG is
ovary.
too low. This could be an
Yeah, beta
ovarian
HCG.
cyst. Yeah, this could be pregnancy of unknown origin.
It is 8 weeks. She mild spotting at 8 weeks gestation. He did the ultrasound, but 8 weeks it's supposed to
8
be
weeks,
there
Yeah.
to appear.
fetal
Hmm.
8 weeks. This is already she is
The sac
supposed
should
to.
be seen. The sac should be seen. But if the sac,
Yeah.
instead of the sac, you are having an adnexal mass. So probably it is it's dying. It's like it's already
failing
failing.
ectopic.
Yeah. So what you can do, you can just give a conservative management and keep looking at the beta HCG for it to become less than 2 or less than 5. Now it's 150. We can keep doing serially after 1 week.
Yeah, I will. For me, I'll look. We need to know if this now we are not sure. Maybe she is miscalculating, or this is a failing pregnancy. So how to differentiate between this and this? It's only one step, and it's very easy.
That is one is doubling, na, to see the doubling time of the beta HCG.
So yeah,
HCG.
Yeah, so we will go for beta HCG. So beta HCG means that we are not giving her anything.
Just expectant.
Expectant.
Yeah. So this is expectant management. So we are going for expectant management. And this is the answer. Let's go. Expectant management with serial beta HCG and follow-up until complete decline is advised with low levels of beta HCG. Okay.
Okay.
So next question. 3.
26-year-old present in her first pregnancy.
Oh yeah, 4. Sorry. What?
3. Number 3.
Oh, sorry. Sorry.
Old present in her first pregnancy at 7-week gestation with lower abdominal pain and spotting. She had beta HCG 2 days ago, was 900 international unit. Her transvaginal scan 2 days show a very low gestational sac with good Doppler flow beyond the internal os, with no sliding sign. Repeat beta HCG today is 1118 international unit. Negative sliding sign.
Cervical pregnancy, cervical ectopic.
Yeah. This is cervical ectopic or cervical pregnancy, and the reason he gave you a negative sliding sign because he don't want you to suspect that this is
abortion.
How
no,
differentiate sliding scar and cervical pregnancy?
Look, there is a difference. There is 3 things that you need to differentiate between.
Okay.
Cesarean scar, ectopic, cervical ectopic, or cervical abortion. Cervical abortion is the only one of the 3 will have sliding sign positive. Because this is not implanted here. It is failing. It is going down. So it is the only one which have the sliding sign negative. The second 2 have sliding sign negative. But the second thing is the level of internal os. If it is above the level of internal os or below the level of internal os. If it is above the level, so this is a cesarean scar.